We'll now demonstrate the breast exam on the task trainer. You need to realize that on an actual patient, there would be a number of other steps and considerations. So draping is always very important. You always want to expose only one breast at a time. The first part of the exam, as usual, is observation. And so we'll ask the patient to lower both sides of the gown so that we can make an observation for any asymmetry between the breasts. There is some very slight natural asymmetry in most women. However, gross asymmetries such as a dimple or nipple retraction that's not chronic, etc., those are important findings. The other part of the exam prior to the actual palpation is to observe the patient in several positions, the first of which is standing upright. Patient can put her hands on her hips to flex the pectoralis muscles, providing a different support, and having the patient lean forward to provide traction that sometimes produces dimpling where there may be a tumor. Those parts of the observation are very important. The other part before we actually get on with the palpation is the patient needs to be properly positioned. Now, the purpose of this is to keep the breast centered over the rib cage. So particularly in a woman who is larger, you want to have her cross her lower legs and put her arm behind her head. And that centers the breast over the rib cage so that you have a place to palpate. With that said, I wanted to go over one other visual finding, and probably more importantly, the pronunciation of the same, and that is peau d'orange, which means skin of the orange in French. And as the name implies, there are dimples in the skin because of edema. So if you have blocked lymphatics, you'll see skin that looks like an orange with multiple dimples. The same happens in any fatty tissue. For example, cellulitis on the abdomen will also have peau d'orange. So the first step is to make the observation. You're looking for any discharge, dimpling, asymmetries, also any rashes around the nipple. You should assume that any infection of the breast or any rash around the areola is most likely a breast problem, sometimes a cancer. So don't assume that a simple course of antibiotics will result in a cure. Typically, women don't get a mastitis unless they're lactating and feeding their child. Anyone who's not lactating with mastitis is considered, it's considered to be a cancer until proven otherwise. Why would you get an infection? Typically, again, it's because of blocked lymphatics, and the edema and loss of flow makes this site more prone to infection. The next step is to outline the borders of the exam: sternum, the clavicle, the inferior border of the breast, and the mid-axillary line. So even if it appears the breast doesn't go back that far, the mid-axillary line is generally where we start. Next, we'll go over palpation of the breast. I'm going to go over the anatomical landmarks once again because they're not exactly intuitive, and we tend to focus on what appears to be the breast. You need to remember that the tail of the breast actually goes all the way up to the clavicle, and there can be breast tissue all the way to the mid-axillary line. The other two borders are more intuitive, the inferior border of the breast and the sternum. One of the key points to doing the breast exam is hand position. You're going to have 3 fingers in a line. You're going to be starting here, and you're going to be making a dime-sized circle. Then you walk the finger over and slide the other fingers. You don't lift and put down for fear of losing the orientation and missing a spot. This is a very specific search pattern, and the search pattern is important. So once again, you're going to be making a dime-sized circle with your 3 fingers. Then you walk over with your index finger, sliding the fingers along the tissue and repeating until you get to one of the aforementioned landmarks. Then you go up to the next row, sort of like mowing a lawn, and the next finger does the walking, etc. You perform this until you get to the middle of the areola, and then you're feeling again for masses under the areola. You do not pinch the areola or squeeze the areola. The only time that you make a special issue is if there is a bloody discharge or other discharge. You can apply your index finger in a radial fashion to see if you can determine which of the glands, which are again arranged radially, might be the source of the bloody discharge, which may help the surgeons. But we don't pinch or squeeze or do anything to the nipple. And then you simply continue making your dime-sized circles with a light, a medium, and a firm pressure. The finger walks once again, light, medium, firm. You'll be surprised at how much pressure you need to find to determine that there's a lump at either a superficial or deep position. You should practice on a palpation model to get that idea. But I would estimate that I'm applying, between 5 and 8 pounds of pressure to my fingers at some point to make sure that I'm making good contact in the back. So then we're continuing with the 3 circles up to the clavicle. And again, you continue the search pattern, sort of lawnmower style, within those borders until you're done.